Hello everyone, good afternoon, and I am Dr. Vyshnavi, your ENT faculty, and I'm here to discuss with all of you radiology in ENT. It's very important for us to know the X-rays and the CT scans from the exam point of view because we've seen the last few exams. There have been a lot of questions where we see that at least one X-ray, one CT, or more than one question always comes from radiological aspects of ENT. So we need to pull our focus here and we need to just quickly revise and brush through the entire content so that once you see the image, there is no confusion in the exam and you can just answer it like this in a jiffy when you're in the exam hall without having any doubt, any confusion, because this basically class summarizes almost all the important X-rays, CTs and the pathologies that could be potentially asked in your exams. So if the audiovisual relay is fine with all of you, kindly give me a thumbs up so that we can get going with the class. Hello, Factor 5, Leiden. What's your name? I have seen you in the last class as well. Good afternoon. So let's begin with the X-ray of the paranasal sinuses. So we know that X-ray is very important for the paranasal sinuses. They always ask us questions on X-rays. So as soon as you see this X-ray, can you tell me what is this view and what is the question that will come here? The thing is, first you need to identify what is the view. You have to look at the X-ray and see, is the chin in the up position or is the chin in the down position? So if the chin is in the up position, like how you want to drink water, what would you call this view as? Very good, Ketan. Factor 5 lead in. Absolutely right. This view is called as your Waters view. So what is this view called as? This is called as your Waters view. Now in Waters view, the mouth has to be closed. But here you see the mouth is closed or mouth is open. What do you see here? So Waters view is occipitomental view, but the mouth is closed. Okay, so this is occipitomental view. But if you have the same plus mouth open, like what you see here, what would you call this view as? Yes, what would you call this as? You would call this as, very good, Manish. This is called as your Pierre's view. So if they give you this image, your answer has to be Pierre's view. If they give you an image with the mouth closed, then your answer has to be Waters view. Now the next question is, it is used to identify which sinus. So the main sinus that we want to identify on this X-ray is going to be which sinus? It's going to be your maxillary sinus. So very important, it is used to identify the maxillary sinus. Now what is the sinus that we can also see here in the image? We can also see the frontal sinus. We can to certain extent also see the ethmoidal air cells, but this is used mainly for identifying which sinus. It is for your maxillary sinus. But if they give you an image based question and ask you what is this, because this has come prior also, then you should know this is frontal. Medial to the eye is going to be your ethmoidal, and what you see in the cheek will be your maxillary. Right? Simple. Now look at this X-ray and see, is the chin up or the chin is down? What do you call this view as? Very simple. All of you quickly tell me, what is this view? It is called as your occipitofrontal view, and this occipitofrontal view is for which sinus? Which sinus are we trying to focus in your occipitofrontal view? Very important, occipitofrontal view is used for identifying which sinus? Yes, it is used for identifying the frontal sinus. So very important, it is used for your frontal sinus. So this name can be asked to you, or they can tell you what is the view, or they can ask you what is the sinus that is going to be viewed on this X-ray. Now they can also give you a lateral view X-ray. This doesn't have any specific name, and then they can ask you a image based question and point out the structure. So can you tell me what is 1, what is 2, what is 3, and what is 4? Can you all label 1, 2, 3, 4 for me? What do you think is 1? Very good, Supriya. 1 is going to be your frontal sinus. Thank you for that answer. This is your frontal sinus. What is 2? Where you see a depression in the roof of this sinus, which is called as sella turcica, that lodges the pituitary gland, from where we can do transnasal, transsphenoidal surgeries also. What is this? This sinus that you see here, where we do the transsphenoidal surgery for pituitary, this sinus that we see here is going to be your sphenoid sinus. How do we identify sphenoid? We look at this depression, which is called as your sella turcica. What you see here in the cheek, which is related to your teeth below, is going to be your maxillary sinus. And between your frontal sinus anteriorly and your sphenoid sinus posteriorly, in between them, these air cells, what will these be called as? These will be called as your ethmoid sinus. So very simple. I'm sure all of you know, if they give you an image based question, you can recognize all of these sinuses. So let's go and see one important image over here. Look at this image. What is this image telling to you? Now we are not looking at the at the view per se. We're trying to look at the pathology. So if you see there is something that is not right, what is not right? I'm giving you an indication. What do you see here? Number 2, look at the maxillary sinus of the right side versus the maxillary sinus of your left side. What do you see? So first of all, what I have drawn with yellow is showing to you the septum. This is your nasal cavity. This is your septum, which we have highlighted here. And this septum is bent, indicating to you that this is a deviated nasal septum. Very, very easy. Okay. Now, if we see the maxillary sinus, right side appears hazy. It is grayish, right? But you look at the left side, it is black. So what does this tell us? This tells us that there is a right maxillary sinusitis, probably a right maxillary sinusitis. Of course, with this X-ray, we are going to correlate with the history, clinical examination, and then come to a final diagnosis. But this is how we recognize on an X-ray what could be the possibility. Let's go to the second pathology. Look at this image. What are you seeing here? Now again, let's mark out the nose in the X-ray. What is happening? This is the nose. This is the septum. Now look at the right nasal cavity and look at the left nasal cavity. Look at the right maxillary sinus and look at the left maxillary sinus. What are you able to visualize? You're able to visualize that the nasal cavity on the left side is hazy. It is grayish. Even the left maxillary sinus is hazy. So the nasal cavity and the maxillary sinus on the left side, both of them are hazy, indicating that probably there is a mass coming from the maxillary sinus and going into the nasal cavity. What do you think is a mass that comes from the maxillary antrum and goes to the nasal cavity and goes to the coina posteriorly, which is unilateral, which is single, which occurs in young people, which occurs due to infection? What is that kind of a mass? Can I say it could be a AC polyp? So did you know aspergilloma will show you a specific double density? Fungal ball will show you double density. I have the image later. So that's not going to be the answer here. And fungal ball or aspergilloma will be confined, if it is fungal ball, only to the sinus. It won't come into the nose. Here we are seeing that the haziness is continuous with that of the maxillary sinus, which is why we take the diagnosis as AC polyp, because we know this is unilateral, this is single, this originates from the maxillary sinus, goes into the nasal cavity, and from there it goes to the coina. So this one we take it as AC polyp. Got it, everyone? Now let's see some of the x-rays for the mastoid. We have seen the x-rays for the paranasal sinuses. Very important are Waters view and Caldwell's view. Let's revise quickly the mastoid views. Is this speed fine or should I go a little fast or a little slow? Let me know. Because we're just trying to revise, I want to pile up and finish up this entire session quickly in 30 minutes. So is this fine with everyone? Quickly tell me if this is fine. Give me a thumbs up so that I know that we are going in the right pace and right time. Okay. Fine. Okay, great. So now let's go to the mastoid view. So when we talk about mastoid views, questions usually do not come from directly, what is the view, how much is the angle, all of that will not be the question, but at least you should know the names. There are 3 x-rays of the mastoid that you should know the names of, because you have to rule out when they're given in your options. Like they'll give you x-ray of the paranasal sinuses and in one of the options you'll have the name of the mastoid x-ray. So to rule out that, we'll have to know the names on a bare minimum. Of course, if you can recall more than this, it's very good, but at least the 3 names you should remember. What are the 3 names? The first one is called as your Schuller's view. The second one is called as your Law's view. And the third one is called as your Townie's view. Of course, there are more than these x-rays that we do, but these three names you should know. So Schuller's laws and Townie's view is something that you should do. So what is Schuller's view? If you do 30 degrees cephalocaudal direction. What do I mean by 30 degrees cephalocaudal direction? So the head is resting on the plate, and if you take the x-ray beam, this is the cephalic and this is the caudal line. From here, if you take a 30 degrees, so if you take a 30-degree angle, it is going to be called as your Schuller's view. Instead of 30 degree, if you just take 15 degrees angle and put the X-ray beam, then we call it as Law's view. So Schuller's and Law's are essentially the same. The only difference is the angle at which the X-ray beam is shot. And the last one is going to be your Townie's view, which is a X-ray beam given 30 degrees to the orbitomeatal line. So from here, this orbitomeatal line, we take a X-ray shot 30 degrees to it. This is called as your Townie's view. Okay. Yes, Priyadarshi, it is for FMG, for NEET PG. These are important, X-rays and radiological images that are important for FMG as well. So please stick on to the session. So can you all tell me what is this that you see here in the pathology? I have marked here with a star. Can you tell me what is this cell? If they ask you identify what is the structure marked in the given image below, what should your answer be? I'm waiting for your answers. Quick. So you see this is the medial wall of the orbit. So Tausif, this is the medial wall of the orbit. Medial to it, all these cells will be called as your ethmoidal air cells. But you see this ethmoidal air cell is inferior and medial to the orbit. So what do you call this ethmoidal cell which is inferior and medial to the orbit? What would this be called as? This would be called as a Haller cell. So Haller cell is a cell that is present inferomedial to the orbit. Okay, so first cell that you see is going to be Agarnacea, Priyadasi. So it's not the Agarnacea. Agarnacea will be seen here only, but it is seen in the more anterior cuts. Why am I saying anterior? Because you've already started to see the middle turbinate, which is present quite posteriorly in our nose. So just in front of it, you would see the Agarnacea. So we are not at the right cut for Agarnacea over here. Now look at this and tell me what is this sign? Where do you get this? Quick. Since you guys want to do it faster, let's do it faster. Can you tell me what is this? Where you see that there is herniation of the orbital contents into the maxillary antrum. We call this sign as the teardrop sign. Yes, very good. And where do you get this teardrop sign? This teardrop sign is seen in blowout fractures. So whenever you have a blowout fracture of the orbit, you're going to get this teardrop sign. Very good. So now let's see more ENT pathologies. Let's see this pathology which we have already discussed on the X-ray. You have seen that the mass is probably originating from the maxillary sinus, going into the nasal cavity, and from there to the nasopharynx. This is a unilateral single mass. What do you think is the diagnosis here? And typically you can see that there is a blackish air shadow present here between the mass and the posterior pharyngeal wall. This sign we call it as the crescent sign. So you see that there is a blackish shadow between the mass and posterior pharyngeal wall. We call this as the crescent sign, also called as dot sign. Where do you get this dot sign or crescent sign? Very good. This is seen in patients with antrochoanal polyp. So this is again a very important PYQ that has already come. Now let us look at this image. This is an image of a normal patient showing to you this is your airway tract and this is going to be your prevertebral soft tissue shadow. This is normal. Now look at this image that you see here. What is happening to the prevertebral soft tissue shadow? Is there a widening or is it the same as you see on the normal X-ray? Of course, you see that there is a widening of the prevertebral soft tissue shadow. Sometimes you can also have air bubbles. Okay. Sometimes you can have air bubbles like this or air fluid level also. So what do you think? Which kind of an abscess? Very good. This would suggest to you the possibility of a retropharyngeal abscess. So this is an X-ray image of retropharyngeal abscess. The prevertebral soft tissue shadow is more than 2 times the size of the body of the vertebra. So you see here, this is the body of the vertebra. So the prevertebral soft tissue shadow is more than the 2 times the size of the body of the vertebra. So this would indicate to you that this is a retropharyngeal abscess. Okay. So let's go to the next image and let us see what is this sign telling to you. As soon as you see this sign, you should know your diagnosis. So can you all tell me what is the diagnosis here? You see that there is swelling of the epiglottis. What is this sign called as? What is this sign? Quick, quick, quick. This is a common PYQ that everybody would have seen. So can you tell me what is this sign? Yes, this is called as the thumb sign, seen in which condition? This is seen in acute epiglottitis. So thumb sign is seen in acute epiglottitis. So very important, thumb sign. Again, a very common PYQ. Now look at this image. This is an X-ray image showing to you a normal laryngeal airway that is going to the trachea. But look at this. Here you see that there is narrowing of the subglottis resembling the steeple of a church. What is this sign called as? This is called as steeple sign, which is seen in which condition? It is seen in acute laryngotracheobronchitis, also called as Croup. Again, a very common repeat. So you should know about this very, very clearly. Now look at this image and tell me, what do you see over here? There is something, again, a very common image that we generally tend to get. What is this image? Can I say that there is a foreign body, a coin, probably? Yes. But with this image, can I conclusively tell that it is in the airway tract or is it in the food passage? Can I tell that? No, I cannot tell that it is in the airway or in the hypopharynx or the esophagus. I cannot tell on this image. I will require a lateral view X-ray. So when I do a lateral view X-ray, I can see that this is the air column that I have anteriorly, and this is the prevertebral soft tissue shadow posteriorly. So where is your foreign body located? In your airway tract or in your digestive tract? Where is it located? Yes, so it is located in your digestive tract. So it's suggesting to you that this is your foreign body in the upper esophagus, because we are above the level of the chest. So we are thinking about a foreign body at the cricopharyngeal sphincter at the level of upper esophagus. So here you will have to do esophagoscopy and remove the foreign body. Now let us go to the next image. Look at this image. What are you seeing here in this image? We have done a barium swallow. We have given a meal mixed with barium to the patient and taken an X-ray. You see that something is getting filled with the barium. What is this? Yes, very good. This is nothing but your pharyngeal pouch, also called as your Zenker's diverticulum. So it's outpouching of the mucosa through which constrictor? Quick, quick, quick. Zenker's diverticulum occurs through which constrictor? It occurs through your inferior constrictor. Very, very good. Now let us go to the next image. Again, a common PYQ and a repeat question. Look at this. At the level of your larynx, you are having a black column of air and a swelling coming from the larynx and going laterally. This is your coronal view. But if I take the same patient's actual view at the level of larynx, because I know this is your thyroid cartilage, you are seeing that there is an air-filled cystic swelling coming from the larynx laterally. What would this be called as? Yes, very good. So why is this air filled? Because it is black in color. So this air filled cystic swelling on the side of the larynx, you should think about laryngocele. So very, very important. It is laryngocele. It is occurring due to dilatation of saccule, which is a part of your ventricle. So whenever the saccule dilates, saccule is present between the false chords and the true chords. So the space between the false chords and true chords is called as the ventricle, and from the ventricle you have the saccule. So if the saccule descends from air, then we say that it is laryngocele. Now let us look at this mastoid image. This leaf-like bone is your petrous bone. This is your inner ear, showing to you the cochlea and the semicircular canals. This ice cream cone is your middle ear. What you see here posteriorly is your mastoids. So compare the diseased side with that of the normal side. What is happening in the normal side? You see it is black, it is air filled. Middle ear is air filled. But look at the mastoid here. Is it air filled or is it hazy? Is it hazy? It is hazy. Even the middle ear is hazy. So what would your diagnosis be? Yes, the answer here is going to be mastoiditis. Acute or chronic depends upon the patient's history. From there, you will take the diagnosis. Now, let us see the same image. This is an image again showing to you something. Look at these air cells. How are these air cells? They are blackish in color. Look at the air cell here in the mastoid. Is it blackish in color or is it become hazy? What do you say? Yes, this is also indicating to you that it is mastoiditis. Here you don't even see the septa. The septa are destroyed. So this is a case of coalescent mastoiditis. So here you can see here between one cell and another cell there are septations. But do you see those septations here? No, they are destroyed. They are suggesting to you that it is a coalescent mastoiditis. Now look at this image. See, this is how a normal carotid artery would look like. This is how a normal jugular bulb be looking like. So that is the area of jugular. So similarly, you can see here, this is your carotid and this is the area of your jugular. In between them, do you see that there is a piece of bone that is present here? Yes, but look at this image. This is your jugular, this is your carotid. Do you see that the bone is present? What you are seeing here, is this bone present or is it eroded? It is eroded. So what do we say here? Whenever there is erosion of the bone between the carotid and the jugular, we call that sign as, anybody? What is that sign called as? That sign is called as Phelps sign, which is seen in which condition? It is seen in glomus jugulaire. So in patients who have glomus tumor, they can have erosion of the bone that is present between the carotid and the jugular. This piece of bone is eroded. That sign we call it as Phelps sign. Okay, so I hope everyone got this. Now this is a common repeat, easy to answer. Look at this image and tell me, what do you see here? Ice cream cone appearance. Again, a very common standard repeat. This is an MRI done with contrast, and MRI with contrast is showing to you something very specific. This is your ice cream cone appearance, and whenever you have an ice cream cone appearance, what do you think of? Yes, it is going to be your acoustic neuroma, also called as your vestibular schwannoma. So acoustic neuroma, vestibular schwannoma means the same. So it is the answer over here. Now look at this. There is something that you see in the nose, and if you see very closely, it has two rings. So if you see these two rings, what do you think it is? It is a button battery in the nose. So it's a foreign body in the nose, probably a button battery. So, Som Subradas, bilateral acoustic neuromas are seen in neurofibromatosis type 2. Here we saw only one side ice cream cone appearance, so we will not take NF2 as our consideration, right? Okay. Now let's look at this image. You see this image, there are areas which is little light gray, areas which are dark gray, and this entire maxillary sinus, entire ethmoid sinus is hazy. Same thing is in the opposite side. So do you see there is areas which are little whitish and whitish gray, and something is blackish gray, two different densities of haziness here? Yes. So whenever you get these double densities, there is one very important diagnosis that you should never ever miss. Can you tell me what is the diagnosis? Anybody? Debankita Das, you are right, it is sinusitis. But what type of sinusitis? Is it acute, chronic, allergic fungal sinusitis? What do you think? Very good, Tausif. It is allergic fungal rhinosinusitis. So whenever you have double densities, very good, you should think about AFRS. This is a very, very important thing, that there are two different densities of haziness in the sinuses, indicating that there is secretion, there is allergic mucin, and there is fungus which contains chitin in their walls, and because of that it appears bright white, and here the rest of them appears a little dark white. So that's about our AFRS. Now what is this cell? This is your sphenoid sinus, and there is extension of the cell posteriorly and laterally, and it can have optic nerve within it. So what would you call this cell as? What would this cell be labeled as? Anybody? I'm waiting for your answers. So this, what you see here, this is going to be your optic nerve. So this is your optic nerve. Yes, very good. This cell is called as your Onodi cell. So Onodi cell is a posterior ethmoidal cell extending into the sphenoid sinus, and it can have optic nerve inside it. Now they can also give you an image-based question that what is this and what is this, because this has come in the FMG exams prior. They have asked you what is this and what is this. So what is the structure here and what is the structures below? So in the floor of the sphenoid sinus, so this is your sphenoid sinus. In the floor you have got two important foramina. The foramina above is going to be your foramina rotundum, and below is going to be your Vidian canal. Okay, so we call this as the Vidian canal. The one that is below is your Vidian canal. The one that is above is going to be your foramen rotundum. So these two are going to be seen in the floor of the sphenoid sinus. Okay. Now let's go and see the next image, which is showing to you something very specific. So if you see here, there is a defect. Now you see this is the roof of the nose, and there is a defect here in the roof of the nose. A dye has been injected via lumbar puncture, and you see that the dye is tracking from the brain into the nose, and you can clearly visualize that this dye is coming through the defect into the nasal cavity. What is this investigation and what is your diagnosis? So your diagnosis will be CSF rhinorrhea, because the CSF is coming into the nose. And when you see this, you should know that the investigation that has been done here is going to be CT cysternography. So very good. Whenever there is a trauma, there can be, break or rupture, or trauma can cause defect at the level of the cribriform plate most commonly. And whenever there is a defect, the CSF can leak. So to identify if there is an active leak, meaning at the moment koi ongoing leak hai ya nahi, for that we do the CT cysternography. We do an LP and we put the dye and we track the dye coming into the nose, and this will tell us that there is an active CSF leak. Okay, now let's look at this fracture. You see here that there is a fracture here in the mandible. What is the most common site where you can have the fracture of the mandible? So this is going to be your subcondylar fracture, which is the most common site of fracture of the mandible. So this is your coronoid process of the mandible, and this is the condylar process of the mandible. In the subcondylar region, this is the most common site because that's the weakest site of the mandible. Now, along with this, you can have a fracture where there is fracture at the level of symphysis menti and bilateral subcondylar region. What would you call this fracture as? This will be called as your parade ground fracture, also called as anybody is, what is this, what is the other name for this? Okay, so I'll wait for your answers. Meanwhile, let me go to the next one, where you see a 3 fracture line at the zygomatico frontal, zygomatico temporal, and zygomatico maxillary. What is this fracture called as? I'm waiting for your answers. This fracture is the second most common fracture of your facial skeleton. Nasal fractures are the most common one. So nasal fractures are the most common. The second most common is going to be your, yes, this is going to be your zygomatic fracture. So zygomatic fracture is also called as tripod fracture. So what happens in the zygomatic fracture? This is the bone of zygoma. So at the zygomatico frontal suture there is a fracture, zygomatico maxillary there is a fracture, and zygomatico temporal there is a fracture line. That is why this is called as zygomatic fracture, is also called as tripod fracture. Okay, and the last image is showing to you something very specific over here. You can see that something has been instilled in the airway tract. So can you tell me what is this? Can anybody tell me what is this? Yes, very good, Priyadashi. This is your tracheostomy tube. This tracheostomy tube, is it in the trachea or has it got displaced? Post tracheostomy, you should do an X-ray and confirm it. So this is an X-ray showing to you that there is a tracheostomy tube. So this completes your most important radiology in ENT. So quickly I will take you through all of the images that we have described in one go, so that you can have a quick understanding of whatever we've discussed so far. So the first one, what we discussed, Priyadashi, this is for you, the Waters view, where the chin is up, occipitomental view, mouth open is going to be your Pieris view. If it is mouth closed, then Waters view. It is the best view for maxillary sinus. Caldwell's view is occipitofrontal view, which is chin down. This is for your frontal sinus. Then lateral view shows you all the sinuses, frontal, ethmoidal, sphenoidal, and maxillary sinus. If you see haziness of a sinus, you'll tell that there is probably sinusitis. If you see haziness of the sinus and the nasal cavity, you'll say it's a polyp. If you take an cephalocaudal view in 30 degrees, you will call it as Schuller's. If you take it in 15 degrees, you'll call it as Law's. And if you take it at 30 degree of the orbitomeatal line, you will call it as Towne's view. Inferomedial to the orbit, you have a cell which is called as your Haller cell. If you have a fracture where you see this teardrop sign, you call it as a blowout fracture. And if you have this crescent sign where there is a air column between the mass and the posterior pharyngeal wall, you call it as the crescent sign or the dot sign. If you see that there is an increase in the prevertebral soft tissue shadow with air bubbles, air fluid level, then you should think about a retropharyngeal abscess. Thumb sign, very good, suggestive to you of acute epiglottitis. Narrowing of the subglottis resembling the steeple of the church is seen in acute laryngotracheobronchitis. When you take a X-ray like this, you don't know it is in the respiratory tract or the digestive tract. For that, you have to take a lateral view. If you see it in the prevertebral soft tissue column, it's in the digestive tract. And if it is in the air column, it is in the respiratory tract. If you do a barium swallow, you can see that there is accumulation of dye in the pouch, which we call it as pharyngeal pouch. And if you see an air-filled cystic swelling on the side of the larynx, you call it as laryngocele. And if you see that there is haziness of the mastoid air cells, you call it as mastoiditis, which can be seen in different forms. And if you see that there is loss of septation, it is coalescent mastoiditis. If you see that there is erosion of the bone which is present here between the carotid and jugular, what will you call it as? You will call that as Phelps sign seen in Glomus tumor. Ice cream cone appearance is seen in which condition? Acoustic neuroma. Foreign body with 2 rings usually will indicate to you button battery. 2 different densities will tell you that it is a AFRS, allergic fungal rhinosinusitis. If you see posterior ethmoidal cell extending into sphenoid sinus having optic nerve within it, what will we call it as? Onodi cell. In the floor of sphenoid sinus, we have foramen rotundum above and Vidian canal below. If there is a defect and you can track the CSF via giving a dye, we call it as CT cysternography. This will tell us an active CSF leak. Subcondylar fracture is the most common site, and this is called as guardsman fracture, also called as parade ground fracture. So I was asking you this, but I didn't see anybody answer. So this is called as guardsman fracture, also called as parade ground fracture, where we have symphysis menti and bilateral subcondylar fracture. The second most fracture that we have is the tripod fracture, where we have 3 fracture lines at the zygomaticofrontal, zygomaticomaxillary, and zygomaticotemporal fracture. And the last we saw was tracheostomy, if it is in place or not, by doing a X-ray of the chest, which shows that the tracheostomy tube is in place, the lungs are well ventilated, and there is no collapse or no displacement of the tube. So I hope everyone has understood this entire session, quick session of important radiological images in ENT. If there's anything that you want me to tell you, please feel free to ask your doubts in the chat box. I will answer them. Go, I'll come. It's not okay. Yeah. Okay, so thank you everyone for being there and taking up this class, and I hope this class is helpful for all of you. If you feel that there's something more that you want to learn from me, please leave that whatever you want to learn from me on the chat box below and in the comment box below. We'll come up with more sessions on those requests that you have asked for us. And if there's anything else that I can help you with, please feel free, and we're always available for you. Thank you and bye-bye.